So last but not the least is your invasive strategy, which is your left heart cath. So if your physical examination and the history, everything pointing towards severe aortic stenosis, and the echo shows not a whole lot of aortic stenosis, then you have to go to the invasive measurement of gradient across that valve to kind of confirm. But again, as I said, the most important thing is your history and examination. That kind of trumps everything else. The echo can show that the patient's got severe aortic stenosis. The invasive test, left heart cath, can show that the patient got severe aortic stenosis. But if your exam and patient history does not fit, and again, I will re-stress that you better confirm that diagnosis with an MRI or something else, because history and exam is the most important thing. So going back, some of the mechanical valves that have evolved over the period of years. One was, number A was a star. This is called a star Edward valve. So it's got a cage outside, a metallic cage, and a silicon ball inside. And this is the ring with this suture. It's a very old valve, and we don't use that anymore. And not many patients are having it, because the patients who had was a long time ago. Because this, there are a lot of problems with it. It causes a lot of hemolysis. It can be a nidus for a clot formation and things like that. But it was a good valve at that time. So then another valve is your single tilting disc valve. So you have a single disc that tilts, allows the blood to go in, and if the blood wants to come back, it kind of stops it. And now the one that we use is your double tilting disc valve. St. Jude makes it. It's a very good valve. You can imagine, even if one of the leaflet gets stuck, the other one is still open, which could be a problem in these patients with single tilting disc. Or if you have a ball that gets stuck or it gets eroded, that can be a problem. And again, the area that the blood has to go through, the valve opening is more in double tilting disc. Last, we come to the anticoagulation. These patients should be on a Coumadin. The NOACs are not recommended at this point of time. What I really want you to know, and this is going to be very clinically relevant, is patients who need to go for surgery. Bridging them or not to bridge them. Boards like to test this. Aortic valve, because of its location and physiology, is a high flow valve. There is a lot of flow across that valve, so the chances of clot are low in the aortic valve. So if these patients are going for surgery, it is okay to hold the Coumadin for a few days, provided the patient was properly anticoagulated before. There is no need for bridging. There is no need for heparin, admitting these patients, giving them Lovenox. Again, as I said, this is because it's a high flow valve. Less chances of clot even if you interrupt the anticoagulation of Coumadin for a few days, with few exceptions. And what are those exceptions? Number one, if that patient is high risk. So for example, the patient already has atrial fibrillation, diabetes, and he's on anticoagulation for that. Obviously, you need to bridge them with the anticoagulant or a Lovenox. Number two, if these patients had clot before. So let's say, for example, the patient is got aortic valve, but he had a clot either on the valve or in the left ventricle before. Obviously, you don't want to interrupt the anticoagulation because they are at high risk. So you need to keep them on Coumadin, or if you need to go and then send them to a surgery, bridge them with Lovenox. And last but not the least is if the patient has got underlying other clotting abnormalities, or if they are not properly anticoagulated in the past and you have a hard time keeping their INR therapeutic, then that would be another indication that you bridge them. So with that I will stop. Given technical difficulties, this talk is in 2 parts. So hope you will like it. Have a good day.